Benshir joining us today. I would like to start by thanking Dr. Avi Portnoy for organizing this seminar. Unfortunately, Avi couldn't be here with us today because he's called for his military service. I think I speak for everybody here, wishing him and all our soldiers a safe return home soon. Now I am honored to present Dr. Marsha Benshir. She's a neuro-optometrist. Dr. Benshir's interest in vision and learning came from her experience in special education. She has been practiced since 1980 and is on staff at multiple rehabilitation hospitals, providing diagnostic, evaluation, and prescribing treatment programs. Dr. Benshir has consulted with the audiology department at Walter Reed Army Medical Center, the Institute of Disabilities Research and Training, Western Pennsylvania School for Deaf, and Ivymount School. She is a fellow of the Neuro-Optometric Rehabilitation Association, and I think a COVD member also.
Yes.
Yes. And in addition to her private practice, she provides a pro bono service for Wonder Warriors, teaches doctors and therapists about vision rehabilitation, and develops new therapy procedures. So today she's here to discuss with us her insights on stroke and the application for optometrists in managing patients suffering from stroke. And without further ado, Dr. Benshir, the stage is yours.
Thank you very much, and it's an honor to be asked to speak. I should also give some credit to my father, who was one of the founders of COVD. But my life went in a bit of a different direction. I was working with severely handicapped children, and Dr. Ben Carson started sending me his patients. So from there, I really took a specialty in neuro-optometric rehabilitation, which is different from vision therapy, and was asked to go on staff at multiple hospitals, which is what I do now. So that I see a very large number of stroke patients, as well as other types of neurologically impaired patients. So optometrists do have a very important role with stroke patients, and it's not just in their care after a stroke. We can help with prevention, with educating our patients to what they should be doing, because we spend more time face-to-face with our patients than many other doctors do when we do an evaluation. We can also help with diagnosing stroke, especially if it's been a minor stroke, and help with rehabilitative treatments. I personally am very active with stroke prevention. I do counsel my patients about their risk factors and what they should do to reduce their risk of stroke. I talk about stopping smoking, although in all honesty, with all my years of practice, I can only count 5 or 6 patients who have stopped smoking because I have convinced them. That's not so easy, but I talk to them about managing their diabetes and their blood pressure. Also, glaucoma patients have a higher than average risk of stroke. It is related, as do migraine patients. And this has to do with the physiology of glaucoma and migraine, which is actually similar to the damage in stroke. I have, in fact, diagnosed strokes that other physicians have missed, because I've had patients who show up with an ocular motor disorder that was not in their history and is very specific to stroke. Sometimes a patient will come in with a field loss that you can tell is neurological, and we can treat a great many problems. So again, We look at the risk factors and how can we keep our patients from having stroke. Smoking and diabetes together are a major issue as far as stroke prevention. In younger patients, this is the combination, one of the most important causes of stroke. In older patients, high blood pressure is more likely to be a primary cause. And as you can tell at the bottom on the slide here, the combination of diabetes and smoking triples the risk of stroke for young patients. And by young patients, we talk about patients between 17 and 49, although in America, the average age for a stroke is 65. So I did look up the incidence of stroke in Israel because that's really more important for this talk. So you can see this is a large number of patients, 15 to 18,000. And those are patients who are actually diagnosed. That's why it varies. It's not so clear. As the population ages, the incidence of stroke will increase. Stroke is a major cause of death in Israel, as it is in America. In young stroke patients, the majority of them are male. When we look at stroke overall, 80% of them are infarcts, a blockage in the blood vessel that causes brain damage. 18% are hemorrhages, bleeding in the brain, and 2% the cause is unclear. Those unclear causes are usually a type of ischemic stroke, meaning when they look at the brain, they see lack of blood flow in an area, but they don't see a cause for that lack of blood flow. The fatality rate from stroke is the same in Israel as in America. Approximately 10% of patients will die. Approximately 80% will survive with some degree of disability, and that is a very broad range. And approximately 10% will appear to have no disability. And that is a very important concept for all of us, because among that 10%, most of them will have a subtle vision problem from their stroke that is missed in the medical diagnosis. In America, in major cities, patients can get vision rehabilitation after stroke. It's not available all over the country. Many patients have to travel to go to a large city to get that care, but we can find it in all 50 states. In Israel, you have to catch up with us. Your medical stroke prevention and treatment is better than ours overall, but vision rehabilitation isn't there yet. And this, I found some statistics on the increase in stroke in Israel. So you can see as the population ages, there's going to be an increase in stroke. And there is a difference in terms of the population distribution, because the Arab population, and they feel in looking into some of the research, it's because of the prevalence of smoking in that population, which is higher than the general population of Israel. But they are expected to increase in stroke at a faster rate than overall. So here's what patients and their families need to know. Stroke usually affects vision. When I say usually, more than 90%. It'll be the 80% with the disability and some of that 10%, if not most of it, that seem to have no disability will have a vision problem, but not necessarily their eyesight. They may see normally, but have a vision problem. It can be ocular motor, it can be peripheral vision, I'll get to that in a little bit. Vision affects everything we do, but very importantly, it affects the patient's ability to participate in their rehabilitation. Vision problems can impact orientation. Does the patient know where they are, where things are? Memory, balance, coordination, eye-hand coordination, reading, using a computer, and driving. Many patients will have difficulty using multifocal lenses after their stroke. If you think in terms of the optics of a progressive lens, a patient who has a binocular vision disorder will have difficulty seeing out of the same part of the lens with both eyes at the same time. That can cause a lot of spatial distortions. Most eye doctors in America don't know how to diagnose or treat the vision problems associated with stroke. And most patients don't know what to tell the doctor when they come in for an exam. They're not going to come in and tell you, I think I have a peripheral vision problem, or I think I have a binocular vision problem. They'll just come in and say, I have a problem, and you have to know how to find it. These are some of the most common vision problems after stroke: double vision, visual field loss, impaired depth perception, poor control of eye movements. You can have normal binocular alignment. You can have normal range of ocular motilities and have very poor control of the eye movements. What I see very commonly is a loss of smooth pursuits. The patients have a series of small saccades or very jerky eye movements. They can have a focusing problem, visual processing impairments. I did a study many years ago when I first started seeing hospital patients. And I pulled the records on the first 200 patients I saw in the first hospital that I was working at. And I compiled this to see, what have we got? What kind of vision problems do we have? And I turned the numbers over to a statistician, which fortunately I have one in the family, to find out what incidence of vision problems and what is the prevalence of different types of vision problems in stroke patients. So the vast majority of them had vision problems, mainly binocular vision problems. And there have been multiple studies in recent years that show the same thing. Binocular vision problems are the most common residual disorder after stroke. 87% of this population had a binocular vision disorder. And this chart shows it very, very easily. Now, we have binocularity problems, ocular motor, strabismus. Now, many of the ocular motor and strabismus patients are included in the binocular vision disorders, but I separated that out because there are different types of ocular motor disorders, and strabismus I felt needed to be in a separate category. And even that was extremely high after stroke. Visual field loss, again, high. I separated out extraocular muscle paralysis because not all patients with strabismus have an ocular motor palsy. I put together all the impairments on the right, and next to it, the very, very small number of patients who had no measurable vision disorder after their stroke. So again, this data confirms that most patients will suffer a vision disorder from their stroke. They are less able to compensate for the sudden vision changes. We as optometrists are able to diagnose most of those vision disorders. And the thing to remember most importantly is a patient with a history of stroke, you must always look at their binocular vision. even if they aren't complaining of double vision. Now, visual field loss is a very serious complication from stroke, and stroke is one of the most common causes of visual field loss. It's usually going to be contralateral. So if you have a right brain stroke, you know you will have left side weakness and you may have left side vision loss, vice versa. But there are many types of stroke. And in COVID, you may have seen, as we did in the hospitals, patients who suffered from a hypoxic brain injury. Now, I had seen many of those types of patients before because I've been doing this for many years. Those patients tend to have visual field constriction. They get a global loss of peripheral vision, similar to what we see in glaucoma, but without the nasal step. This can often be restored, but depending on the severity and how long they have had the impairment, it can be very difficult to bring back substantial peripheral vision. Patients who have stroke have comorbidities like stroke on the retina or stroke on the optic nerve. The incidence of glaucoma is higher in these patients because we're dealing with older patients. They are more prone to macular degeneration and giant cell arteritis. These are all things that also cause visual field problems. So that visual field diagnosis is very important after a stroke. You have to look at, are there multiple factors? What caused the loss? Restoring visual field loss to pathology is beyond my abilities. Stroke, I'll show you in a bit, that we can do. Ischemic optic neuropathy, that's basically a stroke on the optic nerve itself. And that can cause an altitudinal field loss, which many doctors don't understand the implication as far as prescribing a lens. If you have a patient who has an altitudinal field loss, they cannot use multifocal lenses. If they've lost the superior field, they have to do this to see, and now they can only see through the near portion of the lens up close. If they've lost the inferior field, they have to do this to see, and now they're only seeing through the top of the lens. You have to give these patients two separate pair of glasses, whether they like it or not. It is the only way for them to be able to function. You can get other types of sensory loss from stroke. They can have photophobia, they can have phonophobia. Vision loss is more common in right brain stroke than left brain stroke. And again, with right brain stroke, you're likely to have left side motor and sensory loss. With left brain stroke, you're more likely to have right side motor and sensory loss. You're also much more likely to have language impairment after a left brain stroke. But vision impairment is the most commonly overlooked problem and undertreated after stroke and traumatic brain injury. So this is a very interesting case report. I first saw this patient in 2013, and he was a 58-year-old man who was running marathons before his stroke. He was high myope, so he had had retinal detachment with scleral buccal reattachment. And when you see his field, you'll understand why I mentioned that. He had a severe hemorrhagic stroke. They had to do a craniotomy. He had left homonymous hemianopsia, meaning everything gone over here. I saw him in the hospital as a patient. After he was discharged, he went to an optometrist near where he lived, and he did some vision therapy. And he got a little bit of peripheral vision back. 3 years later, he came to me in my office, which was about an hour away. The other doctor was 10 minutes away. And he wanted to know, could he recover more peripheral vision? He had not yet gone back to driving. We started him coming in once a week in the office for an hour-long session of neuro-optometric rehabilitation, which is a little different than vision therapy. It's not exactly the same. And he was also doing vision therapy, vision rehabilitation at home every day. And I want to show you what happened after coming in for 6 weeks. The left side are his fields when I saw him. The right side is 6 weeks later. And that's 3 years after his stroke. The point of this is not just to show you what we can do, but to show you it can be done later. There is no time limit that if we don't find and treat the problems right away, the patient can't get better. Yes, we get better recovery when we start intervention earlier. Any physician, physical therapist, occupational therapist, speech language therapist, they'll all tell you that. But you can work with the patient years later and get improvements. Visual spatial neglect is different from visual field loss. The two kinds of information we must get from our eyes are what things are and where things are. That visual spatial neglect is when the patient has difficulty knowing where they are in space, where other objects and people are, and those relationships. They have difficulty processing movement. It can cause motion sickness. It can even cause symptoms of agoraphobia, a fear of moving in space. It's usually caused by right brain damage. Now, when we give lenses to a patient, and this is something all of us do, is we use lenses, they affect our perception of space. They don't just make the image clearer. Patients who are neurologically impaired have to see something or touch it. They need direct, consistent sensory perception to know. Single vision lenses cause less spatial distortion than multifocal lenses, and sometimes very weak prism powers can be used to reduce nystagmus or visual field impairment. So lenses are a tremendously powerful tool. And I wish we had more time. I would tell you how I use them, but I'll give you a little bit of background. If you're not familiar with it, this is binasal occlusion. This is the world's cheapest biofeedback technique. It works extremely well for many patients who have had visual field loss to stimulate peripheral vision. It reduces the overlap between the two eyes in the paracentral field so that it can reduce double vision. But very importantly, for patients who've had concussion, it reduces many symptoms of post-concussion syndrome. And this shows you exactly what binasal occlusion does to the visual field. So unless you bring it all the way out to the pupils, you still have central overlap. But if the patient is complaining of double vision straight ahead, a slight head tilt reduces that. Rather than in an opaque patch, however, they're still able to see with both eyes at the same time. So you're actually stimulating recovery at the same time as reducing some of their symptoms. These are the visual skills you need for reading. You need acuity, ocular motor skills, accommodation, convergence, and visual language processing. For walking, you need visual motor integration, visual auditory integration, again, ocular motor, visual spatial orientation, peripheral vision, and depth perception. Visual skills needed for driving, very similar to walking, but you need much faster responses to much more input because now you have to compensate for everybody else, not just your own body moving in space. There's a phenomenon called visual midline shift syndrome. It can be caused by a visual field loss. It can even be caused by a physical disability that causes the patient to lean to one side and have unbalanced proprioception through their motor system. These can often be corrected with lenses and with therapy. This shows you a diagram of an anterior visual midline shift. We've all seen elderly patients with walkers with their head bent over looking at the floor. You can move the walker higher so they don't have to lean down, and they still do that. Because, as I said, they're looking at the floor. They are often looking over a bifocal or progressive addition. When you see a patient doing that, the answer may be single vision lenses for ambulation. It can, won't always, but can improve their balance and coordination. And if you work with their physical therapist, you will get even better improvements. A right or left visual midline shift caused by an unbalanced use of the two eyes, binocular vision disorder, can cause a big change in their balance and coordination. Sometimes you do have to occlude an eye to prevent double vision. Use a blur patch. This is simply tape over one lens. It works much better for patients than an opaque patch does. If you can use binasal occlusion, use that. Most of the time it will work brilliantly. But if the patient can't tolerate a blur patch, at least gives some input to that eye and does not teach them to be monocular and does not throw their balance as much. It's hard to see on this picture, but the patient can still see light, movement, and color through that patch. We also use the patient's vision to regain motor function. Dr. Edward Taub did some of the earliest research in recovery of motor function after stroke and brain injury, and he found you must have afferent feedback. In the old days, when a patient had a stroke and couldn't use an arm, they would put the arm in a sling next to their body. As a result, they never regained use of the arm. Then we developed something called constraint therapy, where they did the opposite, stop the other arm and force the use of this arm. But the research shows you must have afferent feedback. You must have an awareness of that limb. Where is it? What is it doing in order to regain motor function? Vision is connected to most of your brain. 80% of the sensory input to the brain is from your vision. That's a lot of afferent feedback. And in fact, there has been research using vision with patients who are paraplegic, no sensory or motor function from the waist down, and they have been able to regain control, become continent, and be able to walk again, all from visual input. I use this every day with my patients. I use their vision to help regain use of a hand. First, they have to see the hand and know where it is before they can learn to use it. And I'm going to show you how this works. 50% of the time, it will work the first time I try it. 50% it does nothing, but I don't know too many therapy techniques that can fix a problem in half of the time, fix it in one session. So this was a patient with a right brain stroke. She had left homonymous hemianopsia and left hemiplegia, no movement of that left hand. Her hand was numb, sitting there on a tray, and I taped a little tiny light to her finger. Let's see if you can get that hand to move. Try and tighten up the hand. See what you can do here. There you go. First time she'd been able to move anything. And when we use vision to do this, we start with the thumb. Once we get the thumb moving voluntarily, index finger, middle finger. You don't even have to bother with the others, they'll get it back. But you always start with the thumb. You can use what we call a finger light. They sell these for parties. It works. You can use a flashing ring like children use at parties. It works. I make micro lasers, very tiny lasers, that I can attach to a patient's thumb or finger, because then I can have them project across a room. So less than a millimeter of movement becomes visible when it's across the room. That little light will move an inch with less than a millimeter of movement. Once they get the afferent feedback, they can regain control. Functional scales are used by doctors and therapists to determine how the patient is doing after a stroke. These are the activities that are evaluated, and as you can see, most of them, almost all, are either visually guided or impacted by the patient's vision. If your patients have vision problems that aren't diagnosed, that means they cannot function as well as they should be able to. You will be able to diagnose and treat many of these problems and improve the patient's recovery. So here is how we start. First, you have to identify the vision disorders. As much as possible, control those vision disorders using lenses. So it means thinking about, what does the patient need to do? What vision do they need to do it when you prescribe the lenses? Acuity is not the primary goal. These patients, by definition, are not driving. They are not reading very small print, and they are not spending hours every day on a computer. They need to be able to tell what things are and where things are and where they are to be able to regain mobility and function. Make sure that the patient has the right glasses and knows when to wear them, and that the people with the patient, be they therapists or family, also know and can tell the patient, put your glasses on. Look at the patient's posture. Are they doing this? Does that mean they have a field loss or neglect or torticollis or a motor problem? What's causing it? Very often, the patient's posture is your first clue that there's a vision problem. You have to keep that in mind when you're prescribing their lenses. If the patient already has glasses, do those glasses make rehab therapy easier or harder? What can you change right now to help the patient? Use blur patches and binasal occlusion instead of covering an eye, because when you cover an eye, you reduce input to the brain and you take away peripheral vision on that side. So you're just changing the problem when you use an eye patch. Don't assume that vision disorders will be permanent. You don't always know what you can fix until you try. Don't assume that given time the patient will get better. They don't. Among the many things that Dr. Taub identified is a phenomenon called learned non-use. The longer the patient has the deficiency, the more they adapt behaviorally to avoid needing that system. And if they don't use it, those pathways in the brain will further degrade. Work from bottom up to integrate your treatment with other therapies and encourage your patients to practice their therapies every single day. Even if they can only do it 5 or 10 minutes at a time, every day. The repetition is what causes new pathways to form in the brain. These are the rules for rehab. They have to know what things are and where they are to participate in rehab. Patients have to remember what they see in order to learn. They have to be able to use vision to guide motor function. They have to integrate vision with auditory and vestibular functions. All of those are simple, straightforward, and we can all address them. Basic concepts for vision recovery, afferent feedback. When we work with the patient, you saw how I used a light on the patient's hand. It is much more effective than you standing there and waving a light. Trust me on that. Exponentially better to use the patient's own body because you're stimulating multiple systems. So you get better recovery of pathways in the brain. You want to break down field neglect to get recovery, and you want to use movement and moving targets. So again, summary, acuity is only one part of vision. Stationary and ambulatory skills differ. Very few activities of daily living are not dependent on vision. Conversely, impaired vision will interfere with most activities of daily living. And impaired vision will also interfere with your patient's memory. If they didn't see it, they won't remember it. And with many stroke patients who are older, if they don't see it, they also may not hear it. So this can make it look like they have dementia, which may or may not be that bad. That's a separate function. And I do have some footnotes for things that I mentioned in the slides. And there are other references I can give you if you need them. I added in the slides on statistics in Israel after I'd put the rest of this together. So I apologize. I didn't put those footnotes here, but I do have those. And there are some specific references that are very, very helpful to learn more about it. Now, some of these books, the first two, Vision Rehabilitation and Neurovisual Processing Rehabilitation, they are really written for optometrists who have some background in vision rehabilitation, but they are well written enough that they can be understood. The diagnosis and management of special populations, is an excellent general book, and much of this applies to stroke patients. And again, the book on neuro-optometry is very, very helpful. So I thank you very much for inviting me to speak, and I'm more than happy to answer any questions that you have. But if you can't if you can't ask them in English, someone will have to translate, because I have Sesame Street level Hebrew skills.
Thank you very much. I think Dr. Freder will be happy to do that. There is any questions? Students can ask in Hebrew and we will translate.
Are there any questions? I have a peripheral question, if I may. When you say if you can't see it, you can't remember it. I remember when we were younger, and at movies they would show these, I don't know what they were, 50 milliseconds, some sort of subliminal advertisement, and they thought that they got us. Later, if my understanding is correct, it was sort of disproved. Is what you had to say about it a support for debunking that theory?
I will tell you that I think those subliminal messages would have to be repeated many, many, many times for there to be any kind of cognitive process or awareness. I do not think that information would integrate.
Thank you.
You're welcome. Now, a lot of what I do, I work with families of stroke patients. They can't come into an office. Some can, most can't. So that I've developed hundreds of techniques that you don't have to have a lot of expensive equipment to be able to use. So that I literally on a daily basis teach patients, their families, and non-optometrists how to do vision rehabilitation. I think any optometrist can successfully do basic vision rehabilitation. And I don't think it's hard to learn, because you're smart enough to get into optometry school. You're smart enough to be an optometrist. It means you can learn this. I'm smart, but I'm not a genius. And if I can do it, you can do it. So there are many, many simple techniques. I mean, how simple is it to put a little light on someone's thumb and see if they can move their hand? Not complicated. I work with head-mounted lasers because patients need to know where their head and eyes are and where they're pointed. We work with mirrors so the patients can learn to see their whole face. But there's a great deal that you can do very, very easily, even if you're not oriented towards a vision therapy type practice. Things that any optometrist can do working with these patients. So I want to encourage everybody to think this way. What can I do to help my patient? Because you can do it in a way that's not hard for you, not hard for the patient, and will help them in their overall recovery.
I'd like to, if I can make a comment.
Yes.
Nice to see you, Marsha, Robert Lederman. I think one thing which would be, I think useful when you work with these patients to bear in mind is the following, that we know that for balance and maintenance of balance, vision is certainly very important, and particularly when our stability is compromised. Meaning when I stand on 2 feet, and I'm able to balance, my vision is less engaged in maintenance of balance, and proprioception and vestibular is really what's maintaining my balance, and therefore vision is free for cognition. Vision is free so I can make the fine motor control required to identify and to be involved in the world of perception of detail. But when my balance is compromised, and everyone can try this just by standing on 2 feet and closing their eyes, and then standing and not feeling a difference, then standing on one leg and then closing your eyes. When you stand on one leg, meaning you're in a compromised situation regarding posture and balance, and you close your eyes, you'll fall over, meaning the minute you stand on one leg, vision suddenly becomes engaged to maintain balance. And this is demonstrated, as I say, if you close your eyes, you'll lose your balance quite quickly in most cases. And so when dealing with people who are compromised in their balance as a result of stroke, I think it's important for the therapist, when listening to the family talk or even the patient talk, to expect to some degree that they will be less aware of details in their surroundings, because their vision, whereas prior to the stroke, they were not using vision so much for maintenance of balance, suddenly they're using vision to a much higher degree in order to survive as they walk through space. And they will be less able to observe and be aware and remember, as you said, detail. And it's not that they have necessarily dementia. You can think of it like this: if any of you have learned to ice skate, or even riding a bicycle for the first time, you wouldn't imagine at that point when you're learning to ice skate that you'd notice all the details about patterns and words around the ice skating rink, because you're in that sort of survival mode. You have that look on your face where you're not noticing detail. You're actually using vision for balance. But as you become more stable, then you can start to notice more of the detail in your surroundings. So I think that's, I hope that's a useful point when working with these patients, to understand that essentially they're going to have a harder time using vision for cognition, because it's otherwise engaged. And so the goals have to be a little different as compared to working with a regular patient.
Your comments are spot on and very, very important. Thank you. So I'm going to take what you've said and make a very strong recommendation to everyone else. Before you write that prescription on a patient who is neurocompromised in any way, put it in a trial frame and watch them walk. You want to see, what do they do sitting in a chair? Give them a manipulative task. Are they tilting their head? Are they leaning? And if their balance is adequate, get them up. And what do they do walking? Even if they use a walker or a cane, you have to see what the lenses will do for that patient. Does it make it easier, or does it make it harder for them to ambulate? If it makes it harder, I don't care what their acuity is, the prescription is not the correct prescription for that patient. And you have to rethink how you can modify it. So I thank you very much for bringing up that point. That is crucial.
Thank you very much. And I really like to thank Dr. Benshir for opening a window to the world of rehabilitation. I appreciate your time to share your knowledge. And I wish to see you soon in Israel in person.
Oh, I hope so. I
Thank you very
promise I will
much.
be there soon. That I promise. I don't care what else is going on. I'll get